what is the major differences in terms of the three major adrenal hormones in terms of their synthesis and action, the cortical hormones?
The major three hormones are aldosterone, cortisol, and androgens. So they are synthesized from the different zones of the adrenal gland. The glomerulosa produces aldosterone, fasciculata produces cortisol, and reticularis produces the androgens. So it depends on the enzyme availability there on the specific zone.
And in terms of the regulators, what are the common regulators, the different zones?
So in fasciculata, the main hormone production is the cortisol. So ACTH is the major regulator in there. In glomerulosa, it is mainly dependent on the renin-angiotensin system as well as the potassium level of the body. And in reticularis, where androgens are produced, it is also dependent on the ACTH level.
So does ACTH play any role in aldosterone synthesis or not?
Sir, ACTH, there is a role in the release but not in the synthesis.
So maybe around 5 to 10% control is there. That is predominantly there. So if based upon that, we want to classify causes of adrenal insufficiency because of ACTH deficiency, ACTH resistance, and finally a primary adrenal insufficiency, what are the feature differences in terms of their electrolytes, sodium, potassium, and pigmentation?
So in adrenal cortical deficiency, there will be a high ACTH level, there will be pigmentation, as well as there will be hyperkalemia as well be there.
Yeah.
In ACTH resistance, sir, there will be pigmentation, ACTH level will be very high, but potassium level will be normal, sir.
Yeah.
And in ACTH deficiency, there will be normal potassium, there will be no pigmentation, and there will be cortisol deficiency.
Okay, sure. So in terms of the action of the different hormones, do you think there are differences in terms of how much hormone is required to maintain the action in terms of, let's say, cortisol versus aldosterone? What is the usual production rate and which deficiency will manifest first?
The aldosterone deficiency will be life-threatening and will not.
Yeah, no, that is fine. So how much aldosterone is produced every day and how much cortisol is produced roughly?
The cortisol roughly 6 to 8 microgram per meter square per day.
Okay, milligram per meter square per day. What about aldosterone?
0.1 milligram
0.1.
per day.
So in that perspective, do you think if somebody has a problem in synthesizing adrenal steroids, would you have a major problem in terms of cortisol deficiency or aldosterone deficiency?
Cortisol deficiency.
Yes, because so even if some amount of zona glomerulosa is functioning, you will produce enough aldosterone to prevent the problems, but your cortisol will be low, resulting in high ACTH. This is the basis of CAH. So you will often find conditions which are labeled as isolated glucocorticoid deficiency. The classical example is familiar glucocorticoid deficiency because of a ACTH resistance. But now we are identifying a number of conditions, including ones which we thought would cause complete adrenal problems like DAX1 defect, like problems in terms of the NRA51, and all those scenarios also, star defects also, which may only present to you with glucocorticoid deficiency because you need very small amount of aldosterone to really act and prevent the crisis from happening. Which endocrine organs are important within the fetus?
Adrenal is one important hormone because it supplies the DHEAS to mother, which converts to estriol.
But for the fetus, I'm not talking about the mother. So first of all, which endocrine organs are quiescent, sleeping during the pregnancy, and which are active?
Like thyroid is sleeping during pregnancy.
And it wakes up around what time?
It wakes up during after the birth.
No, their levels have started going up by around 26 to 28 weeks. That's why you have got this transient hypothyroxemia of prematurity. Yes, so thyroid is less active and it starts to get active around the end of pregnancy. Then parathyroid?
Parathyroid is also regulated by a mother. So
is it active or not?
It is active, but not helping in the regulation of
so it is reacting to fetal calcium levels. If the fetus mother is having too much calcium, the PTH will be suppressed. So this baby will subsequently develop hypocalcemia. If the mother is having hypocalcemia, the PTH will be high and he will later on develop hypercalcemia. What about pancreas?
Pancreas is active during fetal period because if mother has hyperglycemia, there will be the sugar will be transferred to the baby.
So
and
exactly
baby
the
will-
same way as you're trying to say,
Yes.
what happens with somebody who has a parathyroid?
Mm.
If the mother's glucose are high, the baby's islets are going to be hyperstimulated, and that is going to cause hypoglycemia later on. Any other clue that you know that will tell you that okay, intrauterine insulin is important for the body? What happens to the neonates with diabetes in terms of their birth size?
So in front of diabetic mother, they are
No, neonatal diabetes, what happens to their birth size? Is it more or is it less?
in IGF-1 deficiency, they are small. Diabetes.
Diabetes, neonatal diabetes, potassium ATP channel defect, they are SGAs.
SGS.
SGAs, because they don't have insulin, and insulin is the major regulator as far as the intrauterine size is concerned.
Yes.
You are talking about hypoglycemia, that's a different thing altogether. So pancreas plays an important role, but the glucose is directly supplied by the mother. So we need to differentiate organs which are playing a vital role for the baby and organs which are there, they are responding to the environment, but they are not the major regulator. What about pituitary? Is it active?
It is not directly active, sir. It is responds to the stimulus.
Some parts of pituitary are active, like ACTH, you can say okay, but then the proper role is definitely gonadotropins. They have an important role which is going on. AVP, does it have a role in the baby? In the fetal period? No role of AVP pretty much from that perspective. Okay. Carry forward from there, we've talked about the parathyroid, we talked about the thyroid, we talked about pituitary, we talked about pancreas. What about gonads? Are gonads active in the intrauterine period?
Yes, sir.
So is testis more active or ovary more active?
Yes, this more active.
Okay, so this is a confusing statement. When you say testis is more active, what it means is that your testosterone production or the Leydig cell component is very active, while in a female fetus, the interstitial cells are not working. So first enteral follicle happens by around term and first estrogen is detectable there. But if you talk about the germ cell compartment, what's happening? Is the germ cells of the ovary also quiescent, sleeping?
Yes, sir.
No, they are dividing. They get too much divisions. If you look at the number of the oocytes, you will see there's a lot of differentiation, meiosis, and they get disarrested. So they are very, very active. While the Sertoli cell component, as far as the fetus is concerned, after AMH is less active from that perspective. So there is a dichotomy in terms of responsiveness. Now, Alapan, what about adrenals?
Adrenals are
So if a baby doesn't have adrenal, what will happen to will he be born?
if he doesn't have adrenal, he'll not be born.
He'll not be born, he'll die intrautero.
No, he'll not die.
So what happens in CAH? What happens in adrenal hypoplasia? So you can have no adrenal, you can have no thyroid, you can have no pituitary, you can have, of course, no testis, no ovary, you will still be born. Because mother is providing everything. So adrenals in a way is not that important from a fetal perspective in the intrauterine period. And I come back to the question, why is then adrenal producing so much steroids?
In fetal period.
Yes.
It is due to the suppression of the androgens that is coming from the mother.
No. Why is it producing so much? What is the role? It's not doing anything for the baby. Then why is it
It
producing?
is supplying to the mother. And
Yes.
then,
So adrenal in a way is doing a very, very important role. What it is doing it is providing raw material for the mother to produce.
estriol.
And what does estriol do? It will help in sustaining pregnancy. If you don't supply that much, how will it do? So fetus is a factory which is producing raw material for the mother to produce estriol. You can put the fetal adrenal is a factory in that perspective. Now within the adrenal, there are two zones which I have talked about. One is the fetal zone and one is actually the adult zone or the mature zone. They have a different enzyme formation which I'll talk about a bit later. So if I talk about the fetal physiology, we know that the fetus has got a very unique type of adrenal. So when we say fetal adrenal, it also has got adultoid adrenal also. But when I talk about fetal adrenal, it is the large part of adrenal is this fetal adrenal, which has got unique enzyme characteristics. So it has got a low 3 beta HSD, high level of CYP17 and sulfonyl transferase. What does it mean? If somebody is 3 beta HSD deficient, what metabolite will be produced in lot?
DHEA.
EA.
EA.
DHEA, and then you've got a lot of sulfonyl transferase. So you will produce a lot of DHEAS.
Yes.
But because there is no 3 beta HSD, what is not being produced?
Androstenedione.
And
And
most importantly, cortisol will not be
Cortisol.
produced, aldosterone will not be produced.
Yes.
So baby doesn't need that. So it's not producing that. Now this DHEAS, as I discussed, is the major raw material which the mother needs to produce the other hormones, which is then aromatized by the placenta to produce estriol. So there are 3 types of estrogen, which are estradiol.
estradiol, estrone, and estriol.
So how is estradiol produced from? Aromatization of
Estrogen, sir. Estradiol, estrogen. Testosterone.
testosterone and estrone.
Estrone is produced from androstenedione.
Yes. So there are 3 different types of androgens and 3 different types of estrogen. So what I'm talking here is that DHEAS is basically getting converted into estriol, and this mother, that's why the maternal estrogen levels are going sky high during this period. What is the role of doing estriol level in the mother? Have you heard of some tests in which estriol levels are done in the mother?
Mark.
Yeah, triple marker. What is triple marker?
For down screen.
So yes, so triple marker, you're looking at 3 different types of levels, and estriol levels are also done. So in conditions like Down syndrome and other conditions, this could give you a clue that there may be a risk there. But if the baby has a multiple pituitary hormone deficiency, or there is an adrenal problem, the estriol level may be low. So I have seen patient who actually had a low estriol level. They did all the karyotype and everything, Downs was normal, but later on the baby presented to us with multiple pituitary hormone deficiency. So this is an important thing to remember, is that low estriol is not just a marker of aneuploidies, it may also be a marker of a adrenal problem rarely, or a pituitary problem from that perspective. Now suppose the placenta does not produce aromatase. What will happen then?
There will be history of virilization in mother.
Yes. So all this DHEAS will ultimately get passed. There is not you can't just control it. And this DHEAS in the mother will then get converted into androstenedione, testosterone, causing virilization in mother. And where does the placental aromatase come from? What is the origin of placenta? Is it maternal or is it fetal?
Fetal.
Yes. So if the fetus is deficient in aromatase, placenta will also be deficient in that perspective. So this is an important thing to remember from that regards. Now at 10 to 12 weeks, there is a very unique thing which happens. Now I already talked about that adrenal, the large zone is fetal. It's just producing DHEAS, it's just producing that, it has no other role. But at 10 to 12 weeks, something strange happens and the fetus starts producing cortisol. That means there is some zone in the adrenal which has got the capacity to produce cortisol. And why does this child didn't have any cortisol till 10 to 12 weeks? Now suddenly the cortisol is coming up. What is the role of this cortisol?
This cortisol actually suppresses the ACT, so the chance of virilization in the fetus should be.
So the major role of, so when we say that adrenal has got no role, it is an incorrect statement. If there is no adrenal, at 10 to 12 weeks, this cortisol will not be produced. This cortisol is not going to suppress the ACTH. If ACTH is not going to be suppressed, you will have production of other amounts, more DHEAS, overwhelming the fetus, causing virilization of the female fetus. So this is the only role as far as adrenal is concerned. What about aldosterone?
Aldosterone is
Required, not required?
not required because the
Classical time of
not required.
presentation of aldosterone deficiency of resistance is when?
2 weeks after the birth.
Much later. So even in the first 2 weeks, you don't need it. So what about the fetal period? So aldosterone has got limited role. So these things to understand becomes important. Now there is a very active 11 beta HSD2. So 11 beta HSD2 converts cortisol to cortisone. And we've discussed this is present in mineralocorticoid responsive tissue, particularly the the kidneys and other regions. That's why it causes hypertension if you have a problem in 11 beta HSD2. So what would this 11 beta HSD2 do in the placenta?
So it will like maternal drugs like maternal steroids. It will help like dexamethasone crosses directly to
No.
fetus.
So that is you're going a step further. So what does this 11 beta HSD do? Why is it there?
To inactivate the cortisol.
So if suppose mother has got Cushing syndrome, will the baby be affected? You want the baby to be affected?
No, sir.
No. So if you remember, when I talk about fetal physiology, I say which hormones do not cross the placenta? TSH, yes, no.
No,
You want it?
we don't want it.
Because otherwise the baby will become, anybody who is hypothyroid, TSH is high, the baby will become thyrotoxic. Insulin doesn't cross. You don't want insulin to cross because you give insulin, it's going into the baby, it becomes difficult. Cortisol also should not cross because if you see pregnancy, anyway, you have hypercortisolism, all those things, and it's going to go cross, it is going to cause a lot of problem. So cortisol and prednisolone, which are inactivated via the 11 beta HSD, that's why this 11 beta HSD is there. So placenta is a sieve. It allows only those part of hormone which are good for the baby or which are good for the mother. It inactivates the other. It also will be a block. It will also allow transfer. So 11 beta HSD is inactivating cortisol and prednisolone. But here comes your point. So what about dexamethasone?
It crosses directly because
So
it's not-
dexamethasone is not affected by 11 beta HSD. That's why it has got more potency. That's why it's got longer half-life and it can cross clearly. So if you want to treat somebody in which you want to treat the mother and not the child, can you think of any condition which you want to treat the mother and not the child?
so like maternal immune related.
So any of the autoimmune condition, CH,
Yes.
adrenal insufficiency, there you will like to prefer which type of preparation?
Prednisolone or cortisol.
So you will
hydrocortisone,
use either hydrocortisone or cortisol. If you want to treat the baby,
then
you will-
dexamethasone.
so which conditions would you want to treat the baby with steroids in pregnancy?
Produce surfactant.
Yes, so induced surfactant, of course, that's the most common one. And theoretically, when we talk about CAH, we'll discuss people have used prenatal dexamethasone therapy. Although that is an experimental strategy, it's not recommended to prevent virilization in females. So in this scenario, clearly dexamethasone may be considered. Yes, Vibhu. Yeah, so SLE, if you want to treat the baby, if it's causing cardiac block, so then you can consider. But if you reduce the antibody in the mother also, you will be fine. So you'll have to decide about which way you have to decide about. So day 3 child with DSD, Prader 4, no palpable gonads, 46XX, 17 OHP is marginally elevated, labeled as CH. Hydrocortisone was given, the doses were reduced, and despite that, there was no elevation of 17 OHP subsequently. Off steroid, 17 OHP is normal. Now, one specific finding was asked from the mother on a history which gave the clue to the diagnosis.
Maternal variation
So, what is happening here?
is actually the XX-DSD, not the 21 hydroxylase deficiency.
Yeah.
So it is due to the aromatase deficiency. And in aromatase deficiency, we know the maternal virilization history is there always.
Yeah. So this is clearly a case of aromatase deficiency which is causing a problem, and you will later on have delayed puberty which is happening. 26-year-old lady with rheumatoid arthritis, yes. Yeah.
Baby.
Yes. Yeah. No, placenta largely comes from the baby. That's what we discussed. The fetus is the major contributor of placenta. So it is because of the same.
Production of the virilite will not prevent.
No. Baby is producing DHEAS to a large extent throughout the period. Only in that time you have 8 to 12 weeks you have got this cortisol which is being produced. After that the cortisol becomes low. So this DHEAS will continue to be produced. If you don't produce DHEAS, it will be bad for the mother from that perspective. How was this role of steroids in lung maturation discovered? Surfactant, which you were talking about. How did people land up deciding about that? So what were they studying and what did they found?
The effect of dexamethasone on delaying the labor.
Yes, on onset of labor.
Okay.
So what they were looking at is how do fetal steroids, so it's the same thing which we're talking about, how do fetal steroids influence the onset of labor. So this was a study which was being done in Auckland, New Zealand, in the Liggins Institute, and what they were doing is that they were giving steroids to the which will cross the placenta and seeing what the effect is. And what they realized was that because of this, those babies who had those lambs who were premature, they survived if they had received steroid. Then they realized the effect of that. So the basic concept was the same, whether it affects the. So there is a way people say that fetus sends a signal to the adrenal that now I am ready and we can start the parturition. This was their hypothesis to begin with. So yeah.
Normal term child, their lung maturity depends on own cortisol level or how it is come from the mother.
So overall, with maturation itself, it gets maturated. So steroids are artificial maturers. So it's not that you are cortisol deficient. So let's put it this way: if you're cortisol deficient, would you have RDS?
Cortisol could be coming from the source. The cortisol is coming from the mother.
So maybe in a normal scenario, you don't need a cortisol. But cortisol in a pharmacological dose will be maturing it. Let's put it this way. If it's like it's a treatment. Yes. But will they have hyaline membrane disease?
These children we have seen.
So that's what I'm trying to say is that the cortisol is not essential for lung maturation. But if you treat it from outside, it induces lung maturation. If you give a very high dose, this dose is very high. This is a pharmacological dose that you're giving. How much dexamethasone do you give?
We give Dexa 4 doses.
It's a huge dose. So this is going to then induce, it's like a pharmacological dose. So it's not that the steroids are causing lung maturation. It's a normal age process. But if somebody is premature and if you give them steroids at a high dose, that can mature it. Yeah. Okay. So 26-year-old lady with rheumatoid arthritis on prednisolone, she has become pregnant. What do you plan to do? Would you want to stop the drug?
Will continue, sir.
Okay. So will it not affect the baby?
Prednisolone will not cross the placenta, sir.
Yes. So plan would be to continue the same because it is not going to be affected. It is going to be inactivated by the 11 beta HST. 28-year-old girl lady with SLE who has pregnancy of 20 weeks gestation and has found to have fetal heart block. And once you did antibodies, the immunologist found that it's anti-Rho, anti-La positive. Now, which preparation will you like to treat?
Dexamethasone.
Because
It will cross the placenta.
yes, it will cross the placenta. And what will happen to the baby after birth then? Will you be cautious for something or not? So the mother has received dexamethasone for a long time. Baby is fine. There's no heart block. But what would you like to monitor and follow up?
Cortisol levels.
So they will develop, it's like a
Pushing.
HPA suppression. So this is how it will happen. So you have to be very, very cautious because they will be suppressed. So you have to monitor them. I have seen patients who have gone into emergency and those sort of shock scenario also. So be cautious because you need a lot of cortisol immediately after birth.
Cortisol after birth in the baby likely goes.
Yes, so sometimes we have to because the point that's what I'm raising is that if the baby is not producing anything, so dexamethasone will be there for 2-3 days. You have given the mother, it will be there for half-life is there. But after that, if the baby becomes sick, then it is going to be a big problem. So you need to be very cautious in these babies. And if they have birth asphyxia or something, they have a big issue. So you have to start off with physiological steroid supplementation in this scenario. Yeah. So this is important. You use dexamethasone. So this we talked about pregnancy. So we said that adrenal has got the only role of adrenal for the fetus is to produce cortisol at 10 to 12 weeks. That is mainly to prevent virilization. But after birth, you have got a lot of important roles of cortisol. So what is the major role, Dr. Vibha? Postnatally?
Postnatally cortisol maintains
So
blood
when we
sugar.
talk about TRH surge, we also have CRH surge.
Yes.
Which means cortisol is very, very important from that perspective for in terms of the overall stress response. So your cortisol levels have to go up. That becomes important. And the other thing will happen is that, of course, then you will need it for glucose metabolism. So what happens after birth? This placenta is going clearly. You will have increased production of CRF, that's the basic surge, then the ACTH, and then you will have increased production of cortisol. Now, what are the other anatomical changes at birth in adrenal? So is adrenal a small organ compared to the other body or a big organ?
Sir, adrenal is big as compared to the other organs during birth, and there is a change in the zone, the fetal
Yes.
zone and the
Yes,
adrenal.
exactly,
So
yeah.
that happens after birth. The fetal zone
Will shrink, involute.
and the other zones will increase after birth.
Very good. Well, that's what we are talking about. So if you go weight on weight basis, so milligram per kg adrenal per body weight, it is maximum at birth. But a lot of it is just this fetal factory which is producing this DHEA. This is the fetal zone. This zone is of no use. This has to go off from that perspective. So here what's going to happen is that your changes are going to happen in terms of your DHEA's production has to come down, but the sulfonyl transferase activity is also there. What it means is that till the time you have got fetal zone, what is the effect on steroid levels and steroid metabolites that you will see?
So, sulfated COLT levels are high, so sulfated products will be higher.
So what does it mean?
So there are lots of substances are there in the fetal blood.
No, sulfated products being high means what? You will falsely
High, say
Yes.
the high, but it will
So
not
is
be
it
that
functional or not? Those sulfated
not
products?
functional.
So this is
sulfated.
important. These are like bound hormones. So this sulfated cortisol is basically not working, but you will have falsely high level that is there. Now, second point that you were talking about was other metabolites. What do you mean by that?
Some steroid, unrelated.
Like most common
Cortisone.
cortisone. So you will have non-cortisol metabolites which may be picked up by your assay.
Yes.
So when you look at immunoassay, you may have a falsely
Elevated
determination of levels. So when you talk about immunoassay, how does it identify that this is cortisol? So how your machine is saying this is cortisol. How does it know that this is cortisol? So you are using antibodies.
Yes.
Antibodies are against particular regions which are known as epitopes. So is it looking for the whole cortisol molecule or one part of cortisol molecule?
Part, sir.
Part. So like if you want to say you want to detect an elephant, so how will you decide? Suppose your eyes are closed, what will you say? You will feel for the trunk,
Sir.
you will feel for the tail, you will identify. So same for cortisol, what it will say, okay, this region is the most specific. So I'll take these two regions. Like PTH, if we talk about intact PTH, N-terminal PTH or C-terminal, we look at particular targeted regions. Now cortisol and cortisone, what is the difference in structure? The only thing is that they are basically one is OH and one is O, ketone versus all. So there will be a lot of structural similarity. So you may falsely detect this cortisone as cortisol. This may cause a false elevation which may happen. So overall, immunoassays are not reliable in the immediate neonatal period. So what will be the chance you like to do in that regard?
We'll do structural assays.
Yes. So they are.
Mass spectrometry.
So how do they work? So what is E to M ratio?
Mass versus charge ratio.
Charge to mass ratio.
ratio.
So have you heard where is it relevant?
It is actually there is a slide-like thing, and based on the negativity to positivity, the cortisol and cortisones are passed, and which structure have much more masses, it will be fall
So
back.
if you make a magnetic and electric field which are 90 degrees, you will separate the molecules into a different zone based upon two things. Mass may be similar. Cortisol are not too huge, but the charge will be different. So this charge to mass ratio, E to M ratio, is what is going to help you out that this is cortisol and not cortisone. So that is why structural assay, which is GCMS, is the best way to detect the adrenal steroids in the neonatal period. That becomes important. So important point which you discussed was there are a lot of high sulfated products which will cause falsely high levels. High level of cortisone, which is also going to say a falsely high level from that perspective. And then what you can do in that regards is to do a extraction. So when we say extraction, we say that you remove the sulfation. So this is something you want to do. So extraction is better, or you use a GCMS based assay. Having said all that, the cortisol estimation in the immediate neonatal period is unreliable. So a single low cortisol level in the absence of hyponatremia, hypoglycemia, those scenarios you will have, you cannot diagnose adrenal insufficiency in that perspective. So 3-day-old neonate born to a hypopit mother, penile size is 2.1 centimeter. There is a micropenis-like scenario. Sodium is 128, potassium is normal, 8 AM cortisol is 120. So how do you interpret this?
The mother is like, penile is 2.1.
So first of all, which condition can cause hypopit in both mother as well as baby? Can you think of? So inherited forms, do you think?
Not cause.
So unlikely. So this mother actually, we had to treat with everything. So she was on hydrocort, she was on thyroxine, she was on pubertal induction, and then she was given FSH and LH to achieve pregnancy. So now what you're seeing here is that this baby is born. So we were doing evaluation. But if you talk about theoretically, do you think any genetic cause can cause this? So if you have an autosomal dominant cause,
Yes,
that
sir.
can cause. So do you think, what are the autosomal dominant causes of MPHT? So most are sporadic events or they are recessive. So it is unlikely. But then evaluation was being done for the baby because they were very concerned. So how do you interpret these results? Sodium is low.
Sodium is low.
Cortisol is
potassium
low.
is normal. What is
For hyponatremia, cortisol is?
for hyponatremia, cortisol is low.
Yes. So do you think this is pituitary deficiency? There is micropenis also.
We have to look for the other anterior pituitary hormones also.
Like,
Can look for the thyroid hormone in this.
okay.
Slide.
So
This
GCMS also becomes important here. So GCMS clearly was on the lower side. There is micropenis already.
Also, yes.
There is
So,
micropenis and hyponatremia making your pretest probability
High.
high. So in this case, you can of course look at other things, but then of course you have to confirm this cortisol. So on GCMS, the value was low, which confirms that this is actually a cortisol deficiency. Now, can the mother's hydrocortisone, which she was taking, can this cause this picture?
No.
It won't
Will not
cross.
cross.
So it is not going to be causing that picture. So high cortisol level was the culprit. So we have discussed already that adrenal has a huge change, not only at birth, it's one organ which changes dramatically over time. So in the fetus, you have got a large fetal zone, an intermediate zone, and a very small definitive zone, which is like an adultoid adrenal. That's what I was talking about. It has got a low 3-beta HSD, high CYP17 and sulfonyl transferase. So the major product is DHEAS is a major product. Now, in childhood, what is going to happen is that the fetal zone is going to shrink, but it's not going to go together immediately. So it may take 1 month or so. That's why neonatal period, there are a lot of confusions there. The zona glomerulosa becomes bigger. Fasciculata is there, but reticularis is not very much active. So what does it mean? Your major product now is?
Aldosterone and cortisol.
Majorly is cortisol plus aldosterone, of course, is there at a minor amount. So high 3-beta HSD, low CYP17, and cortisol is your major product, and aldosterone will also be in product produced in that perspective. Finally, at puberty, there is a change. So glomerulosa is there, fasciculata is there, and reticularis appears. So what is going to happen now? Your major product will be?
DHS will start.
So DHEAS, so high CYP17, low 3-beta HSD, and you will have a lot of DHEAS which is being produced. So with maturity, you have got different aspect. What determines, we discussed this last time, whether a particular steroidogenic cell will produce aldosterone, cortisol, or DHEAS.
Sir, it is the electron availability at different zone which
Yes,
decides
so
it.
zero electron availability.
Aldosterone will be.
Yes, some amount you will have.
Cortisol.
only hydroxylase, which is cortisol, and high amount you will have a production of 17-hydroxylase, and you will have a production of DHEAS, which will be there. And of course, different regions have got different electrons. So glomerulosa, fasciculata, reticulata. It's not that these cells are different. Their environment is different. That's why they are behaving in a different fashion from that perspective. Which is the most potent, or let's say most prolific steroid producer in the body? Which gland?
In male,
In anywhere, across genders. So most prolific steroid producer.
in male it is testis.
Okay, so testis production is much more than.
Adrenal steroids.
So how much testis is produced every day?
Androgens, it almost 90% of the male testosterone.
No. How much test? I'm not talking about androgen. I'm talking about steroid.
Total steroid. Adrenal would be the
So anything else? Which gland is the most efficient? If you talk about per gram, it is going to produce you the maximum amount of steroids.
corpus luteum.
Yes. So corpus luteum, it's so much that it becomes blue, yellow. So that's the whole name also. So corpus luteum is a very small structure. And how much does progesterone is produced? It's much, much higher. So it's actually quite big as compared to DHEAS. DHEAS whole day, how much you are producing?
20.
So 20 is around 15, 20 of the adult is producing that. But there the levels also go that much and a very small gland. So that is important to remember.
So in males,
So I'm not talking about across genders, I said. So anyone. So obviously you have to compare with that. Na? So now we know that cortisol levels, as we discussed, are low to begin with, because cortisol amount is not very important in the fetal period. The levels are extremely low. But then you have got that CRH surge which happens. So these levels will go up. They will again dip down by day 7. Day 14, they will again come down. And then by around end of the month, the level are going to go rise. So there is a bimodal distribution of cortisol level which is there. So what does it tell you? It tells you that you need to have age-specific cutoffs. You can't have one cutoff for cortisol deficiency in the newborn period. This is important. And if you look at the preterm babies, you will have a more sharper rise, which is there because of the stress factor, which is there from that regards. The production rate typically we know is 10 milligram per meter square per day, and in preterm they will produce 20 milligram per meter square per day. So preterm require higher doses of hydrocortisone as compared to term. Diurnal rhythm is not established in early infancy. It may take up to 3 months, especially if somebody is hospitalized. It's good.